PCR has helped quite a bit in helping treat young women and even older women with symptoms of vaginitis. It's a pretty non-specific type of symptom, and at times the classical medical school aspects in making the diagnosis may not be present in every patient. For years, we would throw antifungals or different forms of vaginal creams and therapies at women to try to improve their condition. And truly, they wouldn't get better all the time, and many times they'd recur rapidly with whatever the symptoms were. What PCR allows us to do is be much more targeted, understanding what the offending agents are, and also add additional risk stratification to them. For example, it may sound like a condition of bacterial vaginosis, but while you're diagnosing that in a PCR setting, you may also detect that the woman has been exposed to HPV, which can be deadly or even carcinogenic in some species. The important aspect of PCR in diagnosing vaginitis is that it is agnostic to its collection. What I mean by that is that it doesn't matter if it's an anaerobic condition, aerobic condition. If the target is present on the PCR panel, then the PCR can pick up the pathogen and we'll know regardless. Based on the symptoms the patient is displaying when they approach us as physicians, we can tend to choose the type of panel more effectively, but sometimes we're not going to get it right on the first time, and we know that. So one of the considerations that I use is something known as reflex testing. So if I think that the patient might have, for example, bacterial vaginosis, and I need to know which pathogens they are. However, that pathogen target list comes back with no pathogens detected, then often I've checked off to reflex to an STI panel, and subsequently what we've identified is, indeed, my initial clinical information was incorrect, and that a secondary infection with an HPV or a HSV or something may be present. Often I'm asked, well, shouldn't you see that difference clinically? Sometimes, for example, for herpes simplex virus, you cannot see the vesicles inside the deeper aspects of the vagina easily, and it's uncomfortable to the patient to essentially place a speculum that deep when she's suffering from clinical symptoms of vaginitis. So in this regard, the symptoms are present as of general vaginitis, but the diagnosis of BV was incorrect, but the reflex testing allowed us to identify the HSV that was the offending agent. The patient population for PCR use is generally, they've got to be symptomatic with a specific condition. In this case, it would sound like vaginitis type symptoms or STI type symptoms they may have. Regardless, they have to be symptomatic. The second is if initial treatment failures fail, for sure you should consider PCR because the diagnosis will likely be hidden somewhere within that PCR panel. And then the third group of women that we look at are those who are in an at-risk situation. For example, high-risk sexual behavior, those women who are immunocompromised. Older women who have lost vaginal estrogen status often have a change in their microbiota, and they will often develop secondary vaginal infections. So these are some of the areas where we look at patients to say, PCR would be beneficial here. Patients that we determine are candidates for PCR include symptomatic patients that are severely symptomatic, those patients who may have failed initial therapy and are persistent with their symptoms would be present here. Also those patients who are at high risk to progress an infection or in the case of an STI, potentially even pass on an infection to another individual. These are patients that we want to check specifically with PCR. So I've been asked about smaller panels for STI testing, smaller panels for vaginitis type symptoms, and my answer to that is always the same. In this instance or in this disease state, it doesn't make sense. Because we know that there are 12 to 14 known pathogens for bacterial vaginosis as an example, and that there are more than 5 sexually transmitted infections, and many of those sexually transmitted infections occur together or can be seen together in the same patient, it would be bad medicine to try to guess at which 5 to choose to put on a panel. Really, you want to use the medical-based evidence and target the numbers that you actually need to. Additionally, we have to remember that fungal infections can be quite problematic in this patient age group as well, particularly as they get older or if they're younger with BV. If I'm going to run the test for both STI and vaginal at the same time, it's usually in a high-risk patient who is sexually active, who is presenting with atypical symptoms or symptoms that may reflect both conditions outright. It is possible to get an STI and then subsequently change the flora within the vagina that secondarily leads to bacterial vaginosis. So both could be going on at the same time. And for sure in those patients, I'm going to test both. To my physician colleagues, I would say, remember, this is for symptomatic patients first and foremost, and it is for those patients who you would deem to have a more complicated presentation or that you need the information quickly to prevent them from getting sicker or more symptomatic.